You are.
And I think that Ali had a question to start with.
Hi. So I had a question for you, Deborah, because we've done a lot of text messaging versus auto dialer versus postcard kind of reminders. I was interested in the high costs of the IVR at Kaiser. I mean, for example, the message preparation was like $800 compared to like $30 for postcards. And it just, I wonder if you could comment, are you doing something that's, I don't know, more elegant and more expensive?
Should probably be down here answering these questions, but I would say because we established or implemented IVR technology, and I think it was because of some grants we had. I think it was a couple of grants where we were targeting patients with asthma anyway. We already had the infrastructure there, so it wasn't that we were buying new servers, buying new technology, but we did factor in things about licensing and things like that. And we had the message, we pretty much used the same message. Joanne, nod when I'm saying the right thing versus when I'm making something up, which is probably where I'm headed shortly. We already had the content from our postcard, so I think we tried to keep the content consistent. So I don't know if I'm getting.
Well, I was just so surprised because whenever we do something by mail, be it postcard or anything, comparing it to any kind of pre-recorded or auto dialer or IVR, it's so much more expensive to do mail. And
well, it is in small sizes, and that's what we showed. That when we targeted 3,000 patients per arm, IVR was much more expensive than postcard. But if you extrapolate out to a bigger group, a larger population, that's when we saw the cost savings. It wasn't at the intervention population length, and Joanne's going to say something.
That's right. So with the server, what we did was we said there's an average of 12 projects per year that are use IVR, and so we took 1/12 of that cost. We recognize that for agencies that don't have IVR existing, it's going to be much more costly, but we wanted to demonstrate what we did.
And I don't think, and in my mind, as true implementation, you're not going to, if you're going to push it out and keep it going, you're not going to be buying a big server every year, or, I mean, the capital cost, and we could get into cost accounting on this, and we did go around with different scenarios on how to best capture that piece, but we feel pretty solid around that would be what our real costs to do that will be.
If I can just jump in on that, an area where I know not quite enough to be dangerous, but it's all Deb's fault about cost issues. Again, I think this is one of the key needs for implementation science, is to report cost. The caveat is, and the good news is, that there are methods, and Deb has a number of the references, you can do this. You don't have to be Nobel laureate health economist to do this. A lot of it is kind of accounting. But the caveat is you do need to do it in a standard way and be relatively comprehensive. And a lot of times people don't. I'll just give you one quick example, and we can move on to your questions. And one thing that Deb has taught me, for example, is often when people are reporting research studies, they don't report the cost to recruit patients or whatever. And the notion is, well, this is a research study and we had to do this. But if you're going to do that in the real world, you need to promote or recruit, somehow. Maybe not exactly the same way you would in a research study. And take that out. Yeah, you may not need the consent, but you do need to recruit. And similarly, like phone call things. I'm thinking a live phone call now. I've looked at a number of them, and huge variability, kind of like when Ali was puzzling over that. But if you look more detail, some of the people are, frankly, if you will, more comprehensive or transparent, and they include costs like training, supervision, and the huge key, getting wrong numbers and not getting people on there. Or like when you're going to meetings, you have staff driving out. They don't count that. They count just the cost when they're right there. So I think the issue is doing it in a standard and transparent way.
Okay, this is, I don't know who to direct this to. Maybe everybody has an opinion about kind of response to D&I more broadly. My very limited experience with, especially the implementation side, is that IRBs are very slow. So we would want to implement, things change, world is different, and then we wait for IRB review and approval and changing consent forms and all that kind of stuff. The other response, Ross, you had mentioned this, that importance of publication in that especially academic world. And for more senior researchers, maybe we can move beyond that. But especially for junior people coming up, that's a huge issue. And just wondering what kind of responses have been out there to address those kind of issues.
I'll start with, and you're here, right? And so what your IRB would be University of Colorado or?
I'm not.
Well, so here's how we're having luck with the IRB part of it, I think. We are basically, when we get a study that might be a 3 or 4 part study, we submit it in modules. So that almost like a participatory thing where to know what you're going to do in phase 2, you have to have done phase 1, and so, as you go through. And at least our IRB, and this took us a while to kind of get them on board with this, turned out the in-person meetings, just like all of we were talking about, the face-to-face meetings with IRB made a huge difference over email and phone. And so that's at least the modular part is really working well for us, because these studies build on each other so much that if you want to tell every step along the way of what you're going to do over a 5-year study, it's virtually impossible if it's a 3 or 4 phase study. The publication part, I think, is, we're not going to say that no longer are, academic publications important, and I do think it varies somewhat by stage of the career. But I do think if people are doing implementation research, that they should think about that vehicle as the first step. Because what our data shows is that researchers think of their effective dissemination as, I do a publication, and then I have this media office, and they might write a press release on it. And that's pretty much what our data are showing. And just to think, if I'm doing the implementation study, I still need to do the publication, but the next steps of that might look a little different than I thought. And it's not just handing it to the PR department. Other thoughts?
Just a couple of quick points. I think not only for this type of work, but I think IRBs are an issue also for community engaged research, certainly for social media research. A lot of IRBs have huge issues with that. But I think they're also trying to change it and aware there are issues. In our own study, I talked about my own health report project. I'd say IRBs was probably one of the single things that slowed it down the most, because we had 9 different research sites, 7 different IRBs, and 7 different interpretations of what you needed to consent, what you didn't, whether you could use incentives, whether you couldn't, what type of, just that sort of thing. Partially as a response to that, and Deb or Julie might want to answer that, I think some of and again, it's easier to do and integrate it if you're part of a network, but I think other networks are trying to develop strategies where essentially there's one central one or one lead IRB that you kind of cede authority to for that study, so you don't get that. And often that can facilitate, particularly in these large studies or projects.
Well, and I'll touch on the publication part. The study's working with Dr. Glasgow. As soon as the IRB is approved, the draft of the first paper is in play. So I don't think lack of publication around D&I has never been an issue. I think 4 or 5 papers, but it's the important part. What are the methods? What's the conceptual model? Different issues around implementation science of the particular target population or other that you're considering here.
Very interesting talks. I had a follow-up question to Julie in terms of the practically how you approach when you say you're targeting, you're trying to understand and compare low versus high adopters. And I'm curious how you've operationalized that. I've done some work like that, and
And some will say, well, there's natural variation, and are these truly different or just part of natural variation that we're seeing? So I was curious how you approach it.
So if I understand your question, all we did was use adoption as a measure of high versus low. And so, for example, one of the initiatives is the use of electronic consults. So we use the proportion for each site, the proportion of electronic consults that they had, that were in their database, the workload database, compared to, it was either, actually I think we measured it two ways, all consults or all outpatient visits. So it's just a measure of adoption. Now, whether that's due to natural variability or whether it's a true measure of implementation success, honestly, we didn't really look much further into that because, again, we're sort of have to move along here and we have to figure out who our high adopters and low adopters are and try to figure out the differences between them.
Are you using like top quintile, low quintile, or top quarter?
Again, it's very pragmatic.
Yeah.
So we figured out how many sites we could reasonably interview if we were going to interview maybe 5 folks per site. So for most of the initiatives, that meant we could do about 8 sites total. So we took the lowest 4 and the highest 4.
Okay. All right.
Very, very practical.
Yeah. Okay.
I have a question for the group where you're getting ready for the next one or given the microphone. Did the measures and kind of the outcomes that we talked about here surprise any of you, particularly those of you from a more traditional biomedical perspective, where adoption or implementation or cost or whatever was really the primary outcome, rather than a biomarker? Or if you look at the figure in your book there that Borsika went over with Enola Proctor's model and that sort of thing. Those things aren't the usual thing that you see in terms of kind of what's the focus or the primary outcome. I'm just wondering if there's any concerns or if that's a surprise or uncomfortableness with people, or do we kind of communicate, or do you get why these things might be important if you want to kind of plug these gaps and address the 17-year issue?
And then I will get over as well. You have a question that is response to that? Okay.
Sure. So this is for all the panelists, as well as perhaps Borsika, since she went over the PRECISE framework, and I hope I'm saying that right, PRECISE? Precise,
everybody says
precise,
it different.
Whatever, tomato. Okay. So, we already learned earlier that there's the 61 different implementation science models, and now there's also the PRECISE evaluation criteria. And I see at the bottom that this is in one of the citations, it's PRECISE, a tool to help trial designers. So I'm wondering your thoughts on how much PRECISE should also be used to complement the existing D&I models, and kind of, does it complement them in a certain way, or how do you think about that as you're trying to let it guide your trial design?
You start with that one.
I'll start. I say PRECISE just because the people that generally developed it are Quebecois, more Canadian French than anything else, but I have no idea. Everybody says it different. Just a couple things about that. I personally do think there's a lot of use for it. I don't see it as a different model or theory or framework. What I see it as is an efficient, transparent, and that word is important, way of describing your design. And what it does is show, and Borsika didn't have enough time, but that little figure, that spoken hub figure that you have in your book, once you've learned how to do those 10 dimensions, you can tell an incredible amount about a study just from that one little figure. And in my experience, it's helped a whole lot, because in the real world, those examples you had, those were kind of straw person examples. There's really no study ever that's been 100% pragmatic, or I wish they wouldn't use this word. The other word is explanatory, but for you it really means efficacy, or more basic, or under more ideal conditions. But what you can tell is what conditions was it more pragmatic and more explanatory. And to me, the reason that transparency is important is a lot of those things are related to potential for generalizability or translation. And I think by saying that, and again, I think we should be clear, there's nothing right or wrong about doing a more efficacy or explanatory study or a pragmatic one. The issue is just being upfront or transparent about reporting it, and then not claiming, if you're doing an efficacy study, that what you're going to do is going to automatically generalize to all the rest of the world. Somebody else here.
That's true.
I was just going to add a very practical addition to that, which is that it's very helpful when you're writing a grant or submitting a paper to a journal that's not very used to this stuff to see an article like that. So honestly, I think it's also a way of shoring up that you in fact do know what you're doing, and a pragmatic trial, for example, really is scientifically sound. So I find myself using, maybe this is a terrible thing, but I find myself using that reference a whole lot just to shore up what I'm doing.
The other thing it's helped is, we didn't give enough background, is it was originated by the consort people. And all of you that publish in a medical journal know, you need to apply to consort guidelines. This has elevated both pragmatic trials and maybe at least inadvertently implementation science more than most things I've seen, because this is put out as well as the PRACIS criteria by the people that do consort work. And for those of you that are really interested, the originators are doing an update, actually. It's going to be called PRACIS 2. It'll probably be a year and a half before it's out and fully vetted.
Well, I just had a comment to the question you asked, Russ, about the outcome measures. And given what I've learned about D&I, I mean, I don't think any of the measures really surprised me completely. But we had an interesting discussion in our group over lunch just about how, like for the field that I'm interested in, it's relatively new and there's more and more research being done in that area. But a lot of the outcome measures haven't really been defined. And like I'm involved with a team that's doing an intervention right now, and there are guidelines available, and I think it's ripe to disseminate them. But we've had a lot of discussion on our team about the right measures to use, and I think that the ones that I see being used here make a lot of sense. I mean, how feasible is it? Is it practical to do? What is the uptake going to be like? So I guess it's really just more of a comment, and I'm sure there's probably others that have similar experiences.
No, and I think that the nice thing, and because I get that sort of similar question a lot of times from junior people, like, am I risking career suicide by entering this new field where there isn't anything? And you can look at it both ways. You can it is risky maybe because it is new and still developing. But I look at it the other way. It's exciting. It is a new field. In your field, like we were talking about, you could be the first. You can write about this stuff and have the original articles in the literature about how to establish these measures and build the frameworks. And so I think that's the way to look at it, because the D&I jargon and all that, it's really not the most friendly, accessible terminology. But if you explain what it is you're trying to do, there's all this research that's not being applied, and we need to figure out better ways to do that. Then people really get it. And that's sort of the way when I do the first public health training course for students, I always say, you have to be able to explain what you do to your grandmother. If you can't do that, then you need to back up and start over. And that's the same thing with our field. We still need to work on, I think.
Hello. So actually something you said just made me think of a question. So with pragmatic randomized trials, is the standard the same in terms of powering on an outcome? So like I actually work on the other side, like the explanatory trial, so we have a main outcome, you power on that outcome, it is your main outcome. Is the standard different?
Anybody else want to take it? Or I'll start, try to be brief. Two different answers. One, if you're writing a grant, you want to do what you said, the same old thing, and at least your primary one should be something that you're pretty solid on, that's a validated measure that you clearly have enough power on. What's different about D&I implementation science is because of this issue of context that Julie talked about much better, we have a much broader focus. So we're interested in a wider range of issues and that sort of thing. So generally, and just grantsmanship, at least what I do, is I'll put those things in generally as secondary aims or something. But I'm very interested in the who, what, where, why questions, those contextual type thing, as well as the other things some people might call generalizable or other outcomes like quality of life or what's the impact on the patient overall and that sort of thing. But again, a lot of the same principles of science and statistics and things apply. You know, you want to try and have a valid, reliable measure. You want to have a general notion that your sample size is large enough to do that and you have enough statistical power.
And I think it depends a lot on who you're writing it to. So I always think about the reviewers of this grant or this study, what are they going to be used to seeing, and sort of slant it primarily that way. I don't know if we're covering much on hybrid designs during this, but you know, the hybrid designs are kind of a new thing that kind of combine effectiveness research and implementation research. And in some ways, that can kind of let you get away with both, because you can have both some effectiveness outcomes as well as some of these developmental implementation outcomes. And then you can write it to sort of two different audiences for reviewers.
I'd have one last comment, and I'm going to look back to you, Ross. If the grant is being submitted to the D&I study section versus some of the other study sections out there, I've sat on Health Services Organization and Delivery and GEMS and PCORI. I think something that goes to D&I can look very different with respect to sample size and effectiveness, et cetera. It's about sample size. Do you have a large enough cohort to disseminate into, or number of settings where you're going to disseminate? They look and feel very different. The applications, the good applications that I saw, I would say.
Yeah, I think that's true.
So we are going to take one more question from you, I think, and then we'll I will take the last question.
Sure. It's not really even a question. I just wanted to share with you, having been a project coordinator for many years, implementation science is long overdue, and that we're finally getting to the point where when you're implementing all of these interventions, you are an implementation scientist. So we're now giving it an official name.
Right. That's great.
So my last question is related to qualitative data and how much it is respected and accepted by the target audience, whether it's providers or other types of target audience. I think all of you talked about some sort of either mixed method or mixed type of data, and some of you actually emphasized the role of qualitative data, so if any of you wanted to comment on that. And especially Julie and actually Ross with your policy work as well.
Mm-hmm. So I just have one sort of interesting anecdote, and really any of my colleagues who are participating in this can comment on it. So we did we're still working on the best way of sharing our findings, as I sort of indicated in our slide. And so we did have one presentation, albeit it was on the phone, but we had our key stakeholders, not the people at the facilities, but the funder, so to speak, the tippy-top office who was rolling out the initiatives. And so remember I said we had two groups, those who were focusing on the quantitative data, and then those of us who were doing the mixed methods, more qualitative. And I have to say they were much more interested in the quantitative data. And so this is different than getting it accepted in publications and such, because I totally agree with you. They are, many more journals are appreciating the importance of the qualitative data for informing the quantitative, these mixed methods approach. So I don't know if this one presentation was indicative of how things are going to go, or maybe we just didn't emphasize them enough, but they were and they have to report to Congress, and Congress is interested in, how much money did you save, and how many travel dollars did you save, where our group was interested in how you disseminate the findings. So again, it just depends on what your stakeholders are interested in. I think and I hope that the qualitative data, which really does focus on or will help us inform this toolkit, will be more useful to the field. But that one little presentation, I was very disappointed that they weren't focused on the recommendations that we had.
Yeah, I think that's all true, and I think the way Julie framed it in her presentation, combining the methods was perfect. It is sometimes counterintuitive. We have this study that Borsika knows where we randomize state legislators, and one group got a story and a qualitative data, another got more data to see what they would remember, act on, relate to, and surprisingly, the quantitative data did a lot better than we thought. Because, I used to work with state legislators all the time, and the old folklore was, 95% of the time a good story trumps the data. In this case, we found that it was different than we thought. So not only is the mixed methods, but you can also use it as part of your implementation strategy to see which method works better for different stakeholders. And I think it is probably stakeholder dependent, but we still have a long way to go in understanding that.
I would just add quickly, as we're getting ready for Allie's comment here, that over my career, I've become increasingly convinced of the importance of qualitative data and really the back and forth together. Generally, the quantitative data given still in many study sections, but fortunately not all anymore. And it's changing. They want to see the outcomes, which gives you the what. But the qualitative gives you the how, the understanding, and particularly going forward, if you want to replicate this, if you want to understand the boundary conditions and that sort of thing. So both with REAIM and other things, increasingly we've tried to bring in and integrate. Maybe one thing as a follow-up, we could send out for NIH, there's been a fairly recent report on mixed methods, kind of best practices for mixed methods that you might want to take a look at, particularly if you're submitting to NIH.
Yeah.
Because I know very well manager at the time, I gave the opportunity to Allie to ask the last question.
Great. It actually isn't a question. I was just going to add to what Russ said. I really strongly believe that we shouldn't be doing implementation science or pragmatic trials without a qualitative component because we don't understand what happens. To that end, Karen Albright, who's a qualitative researcher here, and I just wrote a paper about mixed methods and the challenges that, particularly in publication, because most of our mixed methods studies have to be separated because they're too long.
Yes,
If you include, the methods for both types of designs, it's often too long. So there are very few journals that really allow you to do that well. And I think that's one of the things we need to push on is the journals. And we did successfully just have a mixed methods paper, accepted, but it's been very difficult.